We continue our discussion on coronary artery disease, and I hope you have seen part 1 of coronary artery disease of my lecture. Well, now we talk about investigation of a case of angina pectoris. ECG, it is the best initial test. Okay, that means a patient comes with exertional pain, chest, and typically pain of angina which get reduced on resting. That means you are thinking of angina, you go for ECG. Now in ECG of angina, it may be normal. It's not necessarily that every time we'll get some changes. Otherwise, what we get is ST segment depression. You can see this is the ST segment depression is there. This normal ECG. At time, we may just get non-specific, maybe T-wave inversion can be there. This is the T-wave inversion. And this was ST segment depression. Okay. And something very interestingly, sometimes we may even get ST segment elevation. This we classically get in case of Prince metal angina. Okay. Right. So this ECG is the best initial test. Suppose ECG is normal. Then what next? Then you go for exercise ECG, also known as treadmill test. In short, we call it to be TMT. This is the next investigation. Now, so before I go for the TMT, let me show you what I was talking to you. Normal ECG, this can occur in a patient of angina or maybe ST segment depression. Classically finding this we get in angina. Now, TMT. Let me tell you some basic about what the basic principle of TMT. When we are planning for TMT or so-called stress-induced exercise tests, okay, first we do the resting ECG. Patient lies supine on a bed and we do the recording as usual. After that, we make the patient stand on this TMT machine. And these leads are connected to the ECG machine. Okay. And now patient has to run on this machine, and even BP cuff is also there in the arms. Now we start the machine. Machine start in a slow speed initially. So suppose the resting ECG heart rate is 72. Now as the machine will move, this belt will move, patient has to move automatically. Now the heart rate will increase, definitely increase, maybe 80, 85, and this machine runs for 3 minutes. After 3 minutes, automatically speed increases. Speed increases. Not only the speed increases, even this height, automatically it goes up. It means you are going uphill. Automatically as the speed increases, height increases, now patient has to run faster. And now the heart rate may go up to maybe 95. Again after 3 minutes, speed increases further and even the height also increases further. Now patient has to run faster. So ultimately this is all computerized. Ultimately as the height increases, as the speed increases, the patient has to run faster and the heart rate will increase. So what we are doing is we are artificially causing tachycardia, increased heart rate. Now we know the basic principle in the lecture number 1 we discussed. More the heart rate, more is the oxygen demand. More is the oxygen demand. But as there is some obstruction is there, the demand is more, but supply cannot increase, and that will lead to ischemia. The word we use is inducible ischemia. Why we use this? If you happen to see any report of TMT, you read the report. The report will say the test is positive or negative for inducible ischemia. Let's learn the term inducible. Why inducible? Because we are artificially increasing the heart rate. In that way, we are creating artificial increase in the oxygen demand. And if demand supply is mismatched, it leads to ischemia. Now, the initial ECG was normal in this case. That's why we went for TMT. Suppose this was the initial TMT, normal. And now, when heart rate increases, we start getting ST segment depression. So now we can say the test is positive for inducible ischemia. So I hope you understood the meaning of inducible ischemia, right? So let's see what are the conditions where we may get false positive TMT tests. Sometime we may get false positive TMT test, right? We may start getting the criteria of positive TMT is, now I say, when we are talking about TMT, positive TMT, ST segment should be depressed to more than 1 millimeter for at least more than 0.08 second. So we are talking about criteria of positive TMT, or systolic fall of BP more than 10 millimeter of mercury. Or if we are getting sustained ventricular tachycardia in ECG, or we are getting signs of poor perfusion, cyanosis starts, or pallor starts, that again indicates signs of poor perfusion, or we may get ST segment elevation, and that's typically we get in Prince metal angina. So they are the criteria of positive TMT. Of course, there are some conditions we may get false positive, false negative. I'll discuss very shortly. Now let's see what are the things what we get in TMT test. This is normal, resting stage ECG normal, and after exercise we are getting ST segment depression. Okay, so what we call as inducible ischemia is there. And if you just see the calculated heart rate, here the heart rate is around 75 per minute. How we calculate heart rate? 1500 divided by number of small squares between two R waves. R wave, R wave. How many small squares? 5, 10, 15, 20. Divided by 20. Heart rate is 75. Now in this case, 1500 divided by how many small squares? 5, around 10. So heart rate is 150. Got it? So in 150 heart rate, we got ischemia. And remember, look at this again, normal ECG, and you are getting ST segment elevation is there. Okay, all are the signs of ischemia, inducible ischemia. Well, with this, we move on to the next slide. What is the maximum heart rate we talk about? First of all, maximum heart rate, how we calculate? It's patient age, 220 minus patient age is the maximum heart rate we talk about. Suppose the patient age is 50 years. So 220 minus 50, 170 is the maximum heart rate. Where we can, up to this heart rate, patient can do exercise. We should make the patient to do exercise. What is target heart rate? It's not possible for every patient to achieve maximum heart rate. But even if the patient achieves 85% of the maximum heart rate, then also we say target heart rate is achieved. As for example, we have a patient of 50 years whose maximum heart rate is 175. So if I have to calculate the target heart rate of 85% of 170, it comes out to be approximate 145 per minute. So up to target heart rate patient can do if he can run. That means during that time we may or may not get finding. So what we say, target heart rate is achieved, right? So now, what are the conditions where we may get false positive TMT? That means patients are showing ECG changes but coronary angiography normal. So false positive means ECG findings are there. but coronary angiography is normal, so we call it to be normal. Coronary angiography is normal, we call it false positive TMT. Now, what are the conditions where we may get? Patient already taking digoxin, patient having left bundle branch block, patient having left ventricle hypertrophy, electrolyte imbalance, typically hypo and hyperkalemia, or patient on pacemaker. If these are there is no point in doing TMT because we are bound to get false positive. So in such condition, what test to be done? This I'll discuss very soon. Now, as far as false positive, and second thing what I was talking to you, even in normal case also, patient may be 15% false positive, and patient may have false negative in around 15% cases. That means patient has coronary artery disease, but still TMT may be negative in 15% cases. So now two extra things we learn, even a normal population, false positive in 15% cases and false negative in under 15% cases. So we have got a set of conditions where we may get false positive and false negative. So let us see what to do in such cases. We do pharmacological stress tests. Now what are the indication? This is we do especially in those conditions where patient is not able to exercise. We get one patient who has some problem in the legs. He has osteoarthrosis. He says, doctor, I can't run. Then our aim is to do TMT, and that will do pharmacological stress tests. And what tests is we do, normally we use dobutamine or dipyridamole. What we do, how we do, I'll discuss very soon. Okay, so now we have different sets of TMT tests. So let's have a. So first of all is the routine tests, exercise, ECG, TMT machine I told you. How it does, it will increase heart rate, it increase blood pressure also. And this we do for those who are able to achieve target heart rate. THR stands for target heart rate. I hope you remember, target heart rate was maximum heart rate multiplied by 85% of the maximum heart rate is target heart rate, and not suitable for those patient having LBB, LVH, patient on digoxin, patient on pacemaker, patient unable to reach target heart rate. At time, a person is normal, he start running, but he get fatigued, he is not able to achieve target heart rate. Then we go to other tests. Now we go for this pharmacological stress test, dobutamine test. It is a beta-1 agonist. It main causes increase in heart rate. BP may or may not increase. It is especially useful for those who have a reactive airway disease, that means COPD, asthma, okay, who are not able to run, or these patients who are not able to achieve the target heart rate. Then we switch over to dobutamine stress test. But it is not useful for those who already have tachycardia. We do not use this test. Then we have adenosine or dipyridamole stress test. They are adenosine is a non-selective adenosine agonist, and dipyridamole. But these two drugs, they simply dilate the coronary arteries without increase in heart rate or BP. This point should be noted very carefully. Now how is going to do it? So again, we use for those LBB, LVH, all those conditions where patient was not able to, where exercise test is not possible, we do this test. Okay, now what it does, and I'm sure it's not causing increase in heart rate. So how they are going to act? They dilate the coronary arteries. Okay, what happened? They dilate the coronary artery and increase supply to normal areas. Definitely, patient has already some ischemic vessel. The blood flow to the ischemic vessel will decrease. So they will have a steal of blood flow. More blood flow will go to normal area, less blood will go to abnormal area. Already blood supply is reduced. Now they have shunted the blood from ischemic area to the normal area. Now there will be more ischemia of the myocardium. And more ischemia will manifest in ECG as ECG changes. So I hope you got the answer that why and how adenosine and dipyridamole, without increasing the heart rate, they are going to create ischemia by stealing the blood flow. Now, before we go forward, we have some pre-test probability. Age is a big factor, as we know. The maximum coronary artery disease occur in males in the age of 45 to 55 year, more in males as compared to female. Male-female ratio 4:1. Cardiac risk factor, patient having diabetes, hypertension, smoking, and increased lipid. If they are there, they are definitely risk factor are there. And chest pain characteristic, what we say exertional pain chest, or so called Levine sign positive. Okay, now this low risk patient includes male patient below 40 years or women below 50 years. They constitute low risk. And no significant cardiac risk factor. That means a patient of 35 years come, he's a non-smoker, non-diabetic, non-hypertensive, no lipid increase, but just come with pain chest, some non-specific pain chest. So we consider this as a low risk patient. Now, one very interesting thing, even in a low risk patient of CAD, the patient that I described just now, 35-year male, non-smoker, non-diabetic, non-hypertensive, normal lipids, and he comes with some pain chest, just atypical pain chest, and we are getting positive stress test. It is more likely to be false positive. Remember, I told you 15% cases may be false positive. And at the other end, a negative test in a high risk patient may be a false negative. What I mean to say, I got one patient of 50 years who is diabetic, who is hypertensive, he smokes, and his lipids are increased, but his stress test is negative, so it may be false negative. So that's the importance of pre-test probability. Okay, patient with high risk feature of symptomatic patient. Suppose we get one patient who has a high risk and he's symptomatic. So should we wait for that reports? No, we start treatment immediately. We don't have to wait for these reports to come, other investigation. We keep on doing, right? Next point. And once we start treatment, we also, at the same time, we also plan for the further cardiac evaluation in the form of echo or angiography, depending on what is we are planning. And stress testing is most useful for risk stratification in patient with intermediate risk factor. What do you mean by intermediate risk factor? Let's see how to approach a case of pain chest. Well, patient probability of coronary artery disease, low, intermediate, or high. Low patient just come with a non-specific pain chest. We don't need, no further testing is required. Patient having high risk, we go for therapy. We start therapy immediately. Low dose aspirin or beta blocker, whatever we want, or it may be nitrate. We start immediately and we go for expert evaluation. But those who have intermediate, are they able to do exercise? Yes. Go for do ECG normal or abnormal. If normal ECG is there, go for TMT. TMT test positive, go for angiography. Is not able to do exercise, go for pharmacological stress test. We discussed just now, maybe dipyridamole or dopamine. Positive, go for angiography. ECG is abnormal in the very beginning only, then you go for myocardial perfusion imaging. Positive, go for angiography. So this is how we are going to evaluate a patient of pain chest. Now before I proceed further, let me tell you in the ECG. Well, we all know that this is the aorta, and we have a right coronary artery, and we have a left coronary artery. This is the right coronary artery, and this is a left coronary artery, so-called main stem. Anatomically, there are two arteries, but as far as angiography is concerned, there are three arteries. One is LAD, left anterior descending artery, and other is circumflex artery. Okay, left circumflex. Now, LAD, this one, it supplies the anteroseptal area. Septum part is by LAD, and it is seen in ECG by V1 to V3. Then lateral wall is supplied by left circumflex artery, and this is left circumflex artery. Lateral wall of the left ventricle, of course. In ECG, it represented by L1, AVL, V4 to V6. And these two together make the complete left anterior wall, left main stem, V1 to V6, L1 and AVL. They represent the anterior. That means combination of circumflex and LAD is left main stem. Inferior wall is supplied by right coronary artery, L2, 3, AVF. And the right ventricle is again supplied by right coronary artery, and it is represented by right-sided leads. This you got to know. What do you mean by right-sided leads? The basic concept about right-sided lead is, so when we are doing the recording, this is the sternum, and this is the V1, this is V2 lead, V3, V4, V5, V6. This is a typical lead placement in a normal recording of ECG. But when we are suspecting right ventricular infarction, then this become RV1, this become RV2, this become RV3, RV4, RV5, RV6. That means we do the recording, but now chest lead we place from reverse, V1, V2, V3, V4, and this is known as R right-sided chest leads. And RV4 is to V6 is the classical finding for the right ventricular infarction. Okay, now suppose TMT test is normal. Now what to do? If TMT test is normal, then the next test is echocardiography. Okay, now what we see in echocardiography, first of all, when we do echography, you can see regional wall motion abnormality, what we write as RWMA. What do you mean by regional wall motion abnormality? So this is normal ventricular contraction is there. Suppose there is tissue ischemia is there. Either there will be no movement at all in the myocardium, we call it akinesia, or this is normal, or they have like this thing, less movement, we call it hypokinesia. So no movement is akinesia, and less movement is hypokinesia. They indicate tissue ischemia. Okay, and one more thing that is very useful for echo is ejection fraction, and this indicates what's the status of pump, cardiac pump. And normal ejection fraction, they take as 60 to 72%, but different books they vary. Some books even mention about 55 to 75% also. The different authorities, they write differently. By and large, my idea of telling you is we also check ejection fraction. If ejection fraction is reduced, that indicates pump failure is there. In addition to that, clot, the echocardiography can also look for the clot, thrombus, typically in LA. It may indicate, we can show mitral regurgitation, which is very common after myocardial infarction. VSD, ventricular septal defect, again a big problem in some patient of myocardial infarction, or cardiac tamponade, again due to rupture of myocardial wall in case of MI. Or one more thing, at time we can combine echo with test. That means patient we do TMT plus echo. It definitely has better yield. Why? Now we are visualizing the myocardium in the condition where it is under stress, where more ischemia is picked up. Stress echo is definitely better than echocardiography, and those patients where we can't do stress, we can combine echo with dobutamine test. Again, the idea is to look for the ischemia. Then one more test that we can do is carding, radionuclide imaging. We do technetium scan, and it is injected at rest, and image are obtained in the gated single photon, what we call a SPECT test. And what happened? They are proportional to myocardial blood flow. That means, suppose this the myocardium is there, and this is the infarcted area is there. So we will see blood is there, blood has gone to the normal tissue, and blood has not gone to the ischemic area. So what we get is cold spot. The cold spot like this indicate there is myocardial ischemia is there. It's a very sensitive test, but the disadvantage is that that we can't differentiate between acute from the chronic ischemia. Okay, but otherwise it's a very extremely sensitive test is there. Okay, now at time what happen? You do the test, and this defect remain there for a long time. Fixed defect is there, or you find that defect has disappeared after some time. Defect, the cold spot disappear after some time. This indicate reversible ischemia is there. But if fixed defect is there, that means permanent ischemia is there. Now, for such patient, we are getting patient who has got reversible ischemia or fixed ischemia is there. Then start antiplatelet therapy immediately. Low dose aspirin therapy should be started. Beta blocker should be started to control the heart rate. And patient should be strongly recommended to modify the risk factor like diabetes, control diabetes, hypertension, lipid, and all this thing. So now we can see the gated thallium stress test, such beautifully seen. Look at this. This is during resting state. And now this is the ischemia we are getting. Cold spot we are getting. Again, resting stage, we are getting a lovely ischemic area. Again, this is the resting state, and we are getting tissue ischemia is there. Now, sensitivity of exercise thallium is same as exercise echo. Dipyramidal thallium to dobutamine echo sensitivity is same. And we can also do cardiac MRI. In cardiac MRI, we get late enhancement and late enhancement is a very sensitive test to look for the tissue ischemia. And finally, we go for coronary angiography. We can see direct visualization of the arteries. Okay, so this is the left main stem. This goes into circumflex artery and LAD, which I discussed previously, and this is the right coronary artery. It supplies the right ventricle as well as the inferior wall. So when we are doing angiography, we can see direct anatomical location of the blockage. This is the most accurate test. And when the artery block is more than 70%, we call it to be critical stenosis. For example, this is the coronary artery. Okay, this is normal coronary artery, but if this artery blockage is up to 70%, block is there, then we call as critical stenosis. Well, how we do angiography? We enter usually either via femoral artery, or we can even go via radial artery also. We put a catheter, and catheter come to the root of aorta. Then we inject the dye in the right coronary artery, and after that we inject the dye in the left coronary artery, and this coronary artery blood goes. Suppose this coronary artery is there, and here is the blockage is there. This blockage is there. So now we can see blood is flowing like this. So we can see blockage, and we can calculate by percentage approximate what percentage of the artery is blocked. Okay, now let me show you some of the angiograms. This you can see in LAD, just see it is totally blocked artery. Is there? This is the right coronary artery. It is blocked here. You can see total stoppage of blood going. Now, one very interesting, we have a TIMI grading score. It indicates the flow in the culprit vessel. TIMI grading stands for thrombolysis in myocardial infarction grading system. Now, what is this? Look, first of all, grading is from 0 to 1 to 3. Please note, this is from 0, it's not from 1 to 3. We call the artery is completely blocked here. So we say stage 0. In 1, penetration of obstruction with no distal perfusion is there. This is 1. Or perfusion with slight delay, we call as 2, slow flow. And normal flow is 3. So this we can say that how much obstruction is there. So now if I have to go by this, I think this will be some flow of blood is there. So this will be stage 2. And about this also I think it's little bit of stage, maybe stage 1 we can see, or stage 2. Some little bit of flow is there. So I hope you are clear about the TIMI grading system also. Now the new concept, Egerton score, is very, very important from the exam point of view. We see the calcification in the plaque. Okay, if you can recall lecture number 1, I told you in the non-reversible state of atherosclerosis, the plaque is calcified, and this we calculate by Egerton score. So, and this we can detect by electron beam CT scan. We do electron beam CT scan, and we can see how much artery plaque is calcified, and it tells you the area and density of the calcification. So look at this. This is the artery calcified. Okay, and you use density of calcium, Hausenfeld field, and volume of calcified area. If the artery is totally calcified, then this is not fit for PTCA also. And PET scan or delayed scanning with helium-201, or by improvement of regional functional impairment provoked by low dose dobutamine, all we can detect by all these investigations. Now, last minute revision point, ECG is the best initial test. TMT is done when ECG is normal, and we in those patients who are not able to run, we do pharmacological tests, and after that echo, which indicate regional wall motion abnormality. Cardiac imaging is done by helium scan, and we do cardiac MRI. Angiography is the most confirmatory and most accurate test. TIMI grading system is to look for the flow, and Egerton score is to look for the calcification. Thank you very much for watching this video.